So coming to our next session, may I invite our chairpersons, Dr. Rajat Mukherjee, Dr. R.B. Leela, Dr. Mamata Datta, Dr. Sengupta, please join. Thank you. The first speaker has been sponsored by Ruby General Hospital, and the topic is pyrexia of unknown origin. The speaker is very eminent physician. We know everybody. He is a teacher of medicine also and has developed medicine department in hospitals. He is well known, our respected Dr. Professor Tapas Rai.
Good evening, friends, doctors. Thank you, Somnath and IMA, for bringing me here, respected chairpersons. The topic for discussion is PUO. It can be also labeled as FUO, that means fever of unknown origin or pyrexia of unknown origin. As somebody said, that's better to think of rare manifestations of common diseases than of rare diseases themselves. As William Osler had said in the last century, the three enemies of mankind, three F's: fire, famine, and fever. So with these small words, I harp into this chapter of PUO. It's very easy to say, but difficult to assign. So coming to the physiology, normal body temperature has a regulated mechanism somewhere here in the hypothalamus. This is the place, only of academic interest to us, but that is the place where you have the temperature set point. So how does this fever come? This is known as true fever. I'll discuss factitious fever later on. This occurs when the inflammatory markers like IL-1, IL-6, TNF-alpha, and other cytokines are released from the monocytes and macrophages in response to infection, tissue injuries, drugs, and inflammatory processes, increasing the body's set point. As I already highlighted, there was that set point of the hypothalamus. So the normal body temperature, the highest is 98.6, and that is the set point. Now, few words about the normal psychiatric rhythm. That means in a normal person, there's a difference in temperature of 2 degrees, 6 a.m. and 6 p.m. The highest being in the evening. And this accounts for the increased volume of emergency visits that peaks in the evening. You work in a hospital as a physician, the maximum admissions for fever, they come in the evening because apart from the fever itself, whatever be the cause, there's a rise of temperature, people get very panicky, night is setting in, so get the patient admitted. So we as physicians have a hell of a thing to work at night. Now this is a pictorial representation of what I've already discussed. Infections, monocytes, macrophages, these are the markers of inflammation, and ultimately there's a regulatory mechanism misuse and heat conservation or heat production, resulting in fever. Now, what is PUO? Fever is there, fever, as you all know, but the definitions over the years have changed in this PUO. The latest definition is that fever more than 101 degree Fahrenheit. Why am I mentioning Fahrenheit? Because we are used to Fahrenheit in our daily working principles. On at least 2 occasions, illness should be more than 3 weeks. No known immunocompromised state. I'll discuss this later on. And diagnosis remains uncertain even though history taking, physical examination, obligatory investigations, I have enumerated below. As practitioners in the locality and practitioners at small places, these are the obligatory investigations everybody goes through till he comes to this step 2 and step 3, which I'll discuss later on. I'm not going into details, this is all enlisted here. Now, how do we classify this PUO? One is the classic variety, the other is the nosocomial variety, the other is a neutropenic or immune deficient, and number 4 is the HIV associated. I'll deal one by one. Maybe with the paucity of time, I'll try to make as much as possible. So what is the classic variety is the one we regularly encounter. Temperature, I said, more than 100.9, duration more than 3 weeks, Evaluation, that means the patient has already got 3 visits in the OPDs or 3 visits in the hospital. Common etiologies are infection as we come on day to day, malignancy, collagen vascular disorders. There are many which I'll enumerate later on. Second variety is nosocomial. So what is nosocomial infection? Nosocomial means you are in the hospital for 48 hours, but prior to your admission, you did not have that infection. Now you develop this infection after 48 hours, and even after discharge from the hospital, you have a fever within 30 days that is labeled as nosocomial. Nosocomial is there in hospitals, people working in hospitals. We are really fabricated with the amount of nosocomial infections, and it is usually induced by the healthcare workers. Next comes the immune deficient or the neutropenic, where the neutrophil count is less than 500. Evaluation has been done for more than 3 days. The commonest here are mainly the fungal infections, opportunistic bacterial infections, aspergillosis, candidiasis, blah, blah, lot of fungal infections, and herpes virus. And last but not the least is the HIV. Temperature same, duration more than 4 weeks in outpatients, more than 3 days in indoor patients, and confirmed by the serology, etc. So the common organism here causing fever, HIV itself can cause fever, but certain organisms are very notorious to cause fever in HIV. Cytomegalovirus, Mycobacterium avium intercellularly, Pneumocystis carinii, this is the commonest, pneumonia drug-induced, and Kaposi's sarcoma and lymphomas. Now this is the big list of pyrexia of unknown origin. I know it's very mind-boggling, but you can see that the infections from 20 to 40% are the infections, not 100%, mind it. We always harp on that infection is causing the fever. No, it is only in the tune of 20 to 40%. Commonest, as you all know, the abscesses, the infective endocarditis, toxicosis, brucellosis, Lyme disease, blah, blah, blah. The big list is given here. Next, we come to the malignant disease. Does malignant disease cause fever? Yes. It does cause fever. I am working in a hospital where we have a good oncology ward, and patients are admitted with fever without any obvious infections. And these are all malignant diseases like lymphomas, leukemias, renal cell carcinoma, hepatocellular carcinoma, and other malignancies. So malignancies themselves can cause fever. Then we come to a very interesting side, that is the vasculitis. So vasculitis should be detected in proper time to save the patient. We have the adult still disease, SLE, which everybody knows, granulomatosis, polyangiitis. Now this rheumatology has become a huge subject. It's very difficult to discuss on this stage, a huge subject. And it has got ramification, branching, and a tremendous lot of development has been taken place with the biologicals. Then we have the polymyalgia rheumatica. Only 2 weeks back, I had one case like this, where the patient presented to me to the OPD, fever for 3 days, severe girdle pain, shoulder pain, but no back pain. And ultimately, turned out to be polymyalgia rheumatica. We treated with steroids, and it has a tremendous response. Within 3 days, the patient improved and still doing fine. Then the miscellaneous drug fevers, I'll talk because drug fevers are very, very common. We seldom diagnose drug fever. Thyrotoxicosis, inflammatory bowel disease, sarcoid, granulomatous hepatitis. This can be caused by infection. This can be caused by drugs. There are many etiologies for this. Factitious fever and familial Mediterranean fever. Now, a few words about the factitious fever. I know people in the clinic assume that the patient is telling the truth. We have patients running to the OPD. I'm little cynical because I'm little elderly now. So I emphasize, where is your temperature chart? A guy walks into my clinic 2 days back. He said he's got fever for last 2 years. 2 years. तो हम बोला कि भाई तुम्हारा कुछ चिट्टा है जिसमें देखा, थर्मोमीटर कभी देखा? बोले ना साहब, नहीं तो देखा. तो बोला कैसे मालूम पड़ा? ना बीबी को हाथ देने से लगता है गर्म है, इसीलिए लग रहा है 2 साल से बुखार है. So this is known as factitious fever. Number 2, there can be alibis of not attending office. We have CISF personnel, we have Victoria people coming in, security people in the OPDs. They just feign fever. And top of the line, and when they are going out, they said, 5 दिन का थोड़ा rest दे दीजिए ना. So this is known as factitious fever. Mind it, factitious fever is pretty common. And ultimately, undiagnosed 5 to 25%. Still we are ignorant. Still we cannot diagnose this 5% to 25%. This is a little bit of physiology. Relation with pulse, respiration, and BMI. With every 1 degree rise of Fahrenheit, pulse increases by 10, respiratory rate increases by 4, basic metabolic rate by 7, and oxygen consumption by 13%. Here are the various varieties of fever: hypothermia, subnormal, normal, moderate, high fever, and hyperpyrexia. I'm not going into details. Hyperpyrexia more than 105. Now the types of fever. Why we want to know the types of fever? Because it will be easier for us to diagnose. Many conditions do fall flat on the types of fever. So what is continuous fever? Throughout the day there will be temperature with fluctuations of only 1 degree. That is why it's very important. If you're treating in the OPD, in your clinic, tell the patient to maintain a temperature chart which will take away half your headache. Next is a remittent, above the normal throughout the day, but fluctuations are 1 degree. Intermittent means it's touching the baseline, which is very common, like abscess, bacteremia, and malaria. Relapsing means short episodes of fever, okay, again fever, okay. Malaria, typhoid, and pale Epstein. Now, few conditions which may open your clinical eye. Viral fevers, so that means fever with myalgia. Very common occur in a clinic. Fever with myalgia. There will be viral fevers are the most common. Influenza, polymyositis, as I said. Meningococcal infections, they have a rash also, and sepsis. So out of this, the commonest obviously is the viral fever. And now we are diagnosed this viral fever, we got this biofire panel in the hospital. It's costly. It costs about 12 to 13,000 rupees, where you get 12 viruses which are coming in, including the SARS-CoV also. So you can treat early, you can save the patient, because we have seen many patients are dying of influenza, pneumonia, going into shock. Now these are the fevers with night sweats. Tuberculosis, everybody knows about it. We heard it in our student life. Lymphoma, abscesses. Brucellosis, which is getting quite popular nowadays. Infective endocarditis, and alcohol withdrawal syndrome. Now what is this alcohol withdrawal syndrome? Apart from many aspects, restlessness, cynical behavior, there tends to be a little 1 degree difference in temperature in these alcohol withdrawal syndromes from the baseline. Now fever with, as I said, that 1 degree, how much is the pulse? 10. So here I am coming to the bradycardia and tachycardia. Relative bradycardia means the pulse is not tallying with the temperature. Commonest, as you know, is typhoid. Very, very common. Malaria, meningitis, leptospirosis, pretty common these days. Any viral fever and drug fever. Then you have the relative tachycardia. That means the temperature is, say, 102, but the pulse rate is 140. A lot of toxins come in here. So we have that ketamine, methamphetamine, etc. These are mostly we have seen in the post-operative patients. Now fever with eyes. These are the eye signs of fever. Eye pain, classical temporal arteritis, watering of the eyes, conjunctivitis, dry eyes, SLE, rheumatoid. These are mainly, if you can see, these are mainly collagen vascular disorders and its family which causes these eye signs. Then we have the famous leptospirosis, where you have jaundice, you have fever, and you have this conjunctival effusion initially. Then uveitis, SLE, and sarcoidosis. Fever with rash, you can see here, the days of fever and the days of rash has been enumerated. And in day-to-day practice, obviously dengue, you can find out 6 days of fever, typhoid rash will be 7 days, pox, everything is enumerated here. Fever with jaundice, as I already said, leptospirosis, hepatitis, drug-induced, mainly ATT, alcoholic hepatitis, very common nowadays, cirrhosis of liver, hepatoma, viral fevers, and malaria. Next, fever with generalized lymphadenopathy. That means lymphadenopathy from head to foot. Leukemia, everybody knows, ALL, CLL. Lymphoma, HIV, we have oral manifestations, toxoplasmosis, disseminated tuberculosis, and brucellosis. Fever with hepatosplenomegaly. These are all basically undergraduate talks which I am giving you. Malaria, typhoid, lymphoma, leukemia, infective endocarditis, brucellosis, Kala-Jar. Kala-Jar has got a huge spleen, so really doesn't come in the fever. The fever gets less and the spleen started getting bigger. Fever with mental confusion, HIV, brucellosis. We have a lot of brucellosis cases who have been presenting in the OPD. I had one in Peerless long time back who was in coma for about 5 to 6 days. He had come from Bangladesh and ultimately turned out to be brucellosis. That time brucellosis was pretty rare. We didn't have the kits to diagnose. And then obviously toxic encephalopathy. In all sepsis, you can have a toxic element that's known as toxic encephalopathy. Malignancies associated with PUO, Hodgkin's lymphoma, non-Hodgkin's lymphoma, leukemia, hepatoma, renal cell carcinoma, and CA colon. So if you're dealing with a fever, that means you're dealing with a PUO, don't always think of your infective causes or a viral cause. Look into if the patient is losing weight, if the patient is not eating well, and the patient is having pain, especially in the abdomen, definitely look for CA colon or renal cell carcinomas. And these are the fevers notorious to cause ARDS. If somebody is working in the hospital, these are the common ones: sepsis, leptospirosis, fever with low platelets, dengue, everybody knows. Any viral fever can have low platelets. Leukemia, drug fever, SLE, and HIV infections. Now, I have enumerated, I have given you some pictorials, some leads, like, sort of a Hutchison, the techniques, etc. Now I'll go into the clinical approach. So what is the clinical approach? Obviously, first is the history of presenting illness, acute or is it chronic. The character of the illness, we already enumerated. Any small interventions which have been done, made dental extraction, urinary catheterization. Associated symptoms like chills, rigor, loss of weight, which I have already enumerated. Bone pain, abdominal pain. So you have to take a detailed history. History is not a 2 minutes job. If you are having a PO with you, God help you, it takes a hell of a long time taking the history. And unless the history is complete, you will definitely have a pitfall and you fall in the pit. Now this is the drug fever. This is very interesting. Now, drug fevers are seldom diagnosed. Patient walks in the hospital or is toilet in the hospital, meropenem de diya. Ticloplan de diya. So this is what has killed everyone. And then the fever is not abating. There's a huge list of drugs. Nobody takes a drug history. Nobody takes a drug history, what he has taken actually, what he has taken over the last few days, last maybe 3 to 4 weeks. So any damn drug can cause fever. You see the huge list which can cause fever. Including allopurinol, very, very common we have seen, phenothiazines, less commonly used, nitrofurantoin, commonly used in UTI, minocycline also not regularly used. Then the carbapenems, as I just said, carbapenems, they itself can cause fever. Cimetidine we are not using these days, ranitidine yes. So this is a huge list of drug fever. I'll just explain a drug fever, 1 or 2 words on that. So what is a drug fever? Fever out of proportion to the clinical picture. There will be rigors, there will be myalgia, rash headache, leukocytosis, and market there usually, rule of thumb is you have eosinophilia. Serum sickness, maybe joint pains, maybe, then the proteinurias, abnormal liver function test. So the onset and duration, usually the onset is 1 to 3 weeks after the start of therapy. May not be immediate. That is why it is very important to take the drug history. How long is he taking? What dose is he taking? Is he overdosing himself or not? And the funniest part, we have in hospitals where we are against the wall. Peet theke gachi jaake bole. Then I tell my juniors, bhai, stop everything. Let God come and play. You won't believe in 10-15% cases the fever just goes off. Just goes off. We don't know. So usually these are drug fevers. So that is what I'm saying, remits in 2 to 3 days after the, even in your clinic. So if you're the fourth physician to see a patient, what happens is patient goes shopping from one to other. Not satisfied 2 days, not satisfied 2 days, not satisfied 2 days. The last guy, he just writes the prescription, gives a few investigations, come after 3 days, dawa band rakhiye, it comes down by itself. And that guy gets the credit. So this for you to see that yes, has the drugs which have been given to the patient, have they been justified on the investigations done or on the clinical modalities which are there, and simply stop the drug and see. Fever was there for 3 weeks, so another 3-4 days fever doesn't make a difference unless the patient has got say encephalopathy or pain abdomen or vomiting, something like that. Now the dietary and occupational history, this is very important. People who are dealing with birds, you can have the SARS, you can have the psittacosis. Animal contact, brucellosis, leptospira. Uncooked food, salmonella, hepatitis. So food history, food handlers, what they do, barite godu ache kina, these are very important. We have seen a lot of rural population, mainly there's a big belt around Asansol, Ranigan, where when I was working in PLS, we used to have a lot of patients coming from that side, and mostly they were having, these cows and bachas in their thing. So that was very common. They were having brucellosis. Now comes the physical examination, these are already emanated, pattern of fever, weight loss, then the examination, clubbing is there or not, vascularity changes, Raynaud's phenomena. You look to the arms, drug injection site, this is very important. Nowadays we have the people with the tattoos.
So
that is
1 minute more.
Okay, sorry. I know it's very short, very big. Anyway, so physical examination, I have actually not gone into the details now. This is a physical examination, just cut it short. These are the tests which have to be done, screening tests. Stage 1, if you don't compete with the stage 1, you go to stage 2, and then the stage 3. And these are the diagnostic tests which are very pinpoint, ELISA, smear test, echocardiography, bone scan, viral culture, etc. This I'll skip. Then the nosocomial, what to do, neutropenic. I'm very, very sorry, the time is so short. So these are the neutropenic things. HIV associated, I've already said. Now few words about the PET scan which has come into vogue recently. What is a PET scan? Can you give me just 2 minutes? So there are 3 scans in our armatorium. One is the CT scan, the other is MRI, the other is the PET scan. So what does CT scan does? X-ray. What does MRI done? Radio waves, magnet. What the PET done? It has a media from glucose, the uptake of glucose by the cells, and you get a dynamic picture. This is the difference. A CT doesn't give you a dynamic picture. MRI doesn't give you a dynamic picture, but PET scan will give you a dynamic picture. And now, apart from PET, was used, or still used for detection of malignancies, detection of cerebral disorders, detection of heart disorders. But now in vogue, it picks up the inflammatory areas and can guide you to that. So here is one case where there was, you can see there, abscess. So it gives you a clear picture how much is there, and then you repeat the PET scan, and then you can see the difference. This is a chart in Harrison, given how you go about it. Don't lose hope. Don't lose hope. Thank you.
So we can conclude. Yeah.
Thank you,
No,
Tapasda,
okay.
for your excellent presentation.
Afterwards.
We call Dr. Roy as our beloved Tapasda.
নাইট্রোফুরনটা নিয়ে জিজ্ঞেস করছে, ওই পাইরেক্সিয়া ফান্নন অরিজিনে ছিল, ড্রাগ ফিভারের একটা কজ।
Thank you. Now I would like to request Now I would request our chairpersons to felicitate our Dr. Tapas Rai, teacher and a very senior physician. We are really honored to have Dr. Rai here for his presentation. Thank you, sir. Thank you very much.